Hello, people. So, urinary tract infections, if I would define them simply, are infections that affect parts of the urinary tract. And in frequency, only the respiratory tract infections are more frequent in humans than urinary tract infections. So, they take the urinary tract infections take the second place, the silver medal in frequency of infections in humans. So before we start to talk about these infections, we will only briefly analyze the basic anatomy of the urinary tract. So the main organ obviously is the kidney, and we have two kidneys. The right kidney, so this would be the right kidney and this would be the left kidney, is a little bit lower because up here we have the liver. And the liver pushes the right kidney a little bit down. The blood supply for the kidneys comes from the abdominal aorta, which has two renal arterioles, so arteria renalis in Latin, and the blood goes back into the system through the renal veins. So this would be the vena renalis, and they go into the inferior caval vein, so the inferior vena cava. The kidneys have above them adrenal glands. So adrenal glands are sitting on the upper pole of the kidney. Out of the kidney goes the ureter. And the kidney is basically, if I would put it simply, an organ that is filtering blood and creating urine. And urine is going down the ureter, and it is going down in the bladder, and then when it has reached a certain amount in the bladder, it is being secreted through the urethra in the outside, into the outside. The upper parts of the urinary tract are the parts above the bladder. The lower parts of our urinary tract are the bladder and everything that is underneath it. So if I would take this kidney and enlarge it a little bit, so we can only see a little bit of its complex structure. We have two kidneys, and the main functional element of the kidney is the nephron, and every kidney has 1 million nephrons, and that constitutes most of the parenchyma of the kidney. So if we go from the capsule to the ureter, we have this fibrous capsule. So this structure is the fibrous capsule shielding the kidney, and the kidney has also a lot of adipose tissue around it, surrounding it for protection. Then the kidney has the cortex. So this would be the renal cortex, and this part, it would be the renal medulla. So in the renal medulla we have these structures. These structures are called renal pyramids. So the renal pyramid. The renal pyramid has this tip that is pointing into the outside, so to the ureter, and this tip is actually called the papilla, or the papilla renalis in Latin. The tip is pointing to these structures. These structures are actually called the calyx. So we have many of these smaller called minor calyx, and when they fuse into one of these bigger ones, this is a major calyx. And when a few of these major calyxes fuse, they make up the renal pelvis, and the renal pelvis continues into the ureter. So the structures that enter and that go out of the kidney are actually going through this passageway, or this window, that is the hilum. So this is the hilum of the kidney, and the hilum is leading into this space, and this space is called the renal sinus. So the renal sinus contains all of these structures and also many blood vessels. These would be blood vessels and adipose tissue. The kidney is divided into kidney lobes and kidney lobules. So the part of cortex and medulla that is sitting between two renal columns, and this is a renal column. So the parts between the renal pyramids. So these are two renal pyramids, and this part of parenchyma that is in between them is a renal column. Half of each renal column and a renal pyramid with the cortex and the medulla are actually called the kidney lobe. Smaller parts of the cortex that are sitting between two cortical labyrinths. So these parts of the cortex are called cortical labyrinths, and these parts are called medullary rays. And in between halves of two cortical labyrinths, we have the kidney lobule. So this is how structurally people have divided up the kidney. Now, the elements that are important when we talk about the kidney are also the urinary tract pathways that are going down. So the ureter that is going into the bladder, and the bladder is continuing with the urethra. There are some differences between males and females, especially that the males have this organ called the prostata that is underneath the bladder. So now, the position of the kidneys in our body is behind the peritoneum. So if this would be the intestines, so this would represent the intestines, this would be the pancreas, this would be, for example, the liver, and this would be the spleen. We see that these structures, and these are the kidneys, are located behind the intestines and the peritoneum. So this is the retroperitoneum space where the kidneys are sitting, and this is the section where they are sitting. So it is logical that if we have a kidney infection, the pain will be projecting in this part. So that is why in a physical examination, if the patient has flank pain, we can suspect a problem in the retroperitoneum or a problem with the kidneys if we also have other clinical information. This would be the aorta, and this would be the inferior caval vein. So now the important elements also to consider in urinary tract infections are that urinary tract infections have different groups of people that they are associated with in different years of life. So if I would make this more simple, basically, if we look at patients, newborns, in the first year of life, so this would represent the first year of life. Our male patient have a little bit higher incidence of urinary tract infections than females. And the reason for that is that in this period, congenital urinary tract abnormalities are more common in males, and these actually are a risk factor for having a urinary tract infection. That is why in the neonatal period, males get this infection a little bit more frequent than women. But after death, and especially in the reproductive years of our life, so somewhere from 15 to 45, 50 years of life, women are the main patients. And the main pathogen that is infecting the urinary tract is E. coli. So E. coli is definitely the most prevalent factor leading to infection, and that is mostly a bladder infection and an infection of the urethra that is simple. The E. coli is not the only pathogen, so also other pathogens like Proteus, Klebsiella, Neisseria, Chlamydia. There are so many of these pathogens that are also a possibility for urinary tract infections, or like Candida, but E. coli is the one we see the most. These pathogens are actually present in severe cases or more complicated cases or cases with comorbidity, and other pathogens are also present as part of sexually transmitted diseases. After 50 years, we also see another spike in male patients because in this time the male patients have problems with the prostata, and they have prostata hypertrophy. And because of this prostata hypertrophy, they have more commonly present urinary tract infections. So this is the basic distribution, and the take-home information is that women are the predominant patients, and we will now see why that is the case. So we will look at urinary tract infections through the risk factors. If we analyze the risk factors adequately, we will definitely have a clear understanding of the pathophysiology of urinary tract infections. Urinary tract infections happen in two ways. So the major pathway, the primary pathway of infection is an ascending pathway. So the urinary pathogen, for example E. coli, enters the urethra and then is ascending up into the bladder, and then if it stays untreated, it goes up the ureter, and then eventually it reaches the kidney. So this pathway of infection, the ascending pathway, is the primary way of infection. Ascending. So this is definitely the primary way, and it is accounting probably for 98% of infections are going this way. About 2% of infections come with the blood, so the distribution of the pathogen is hematogenous. So these patients probably have many comorbidities. They have impairment of the immune system, and the bacteria can, with the blood, come into the kidney and cause an infection. So, but that is not the case in most of the patients. So only 2% of patients have a hematogenous dissemination into the urinary tract. Now, let's analyze these risk factors. So I divided the risk factors into two groups. One group are risk factors that affect women and that actually explain why urinary tract infections are so common in female patients. And the other group of risk factors are risk factors that can affect anyone, any patient. And the first group of risk factors, the first important risk factor that is leading to so many urinary tract infections in women is the female anatomy. So this is definitely a very important element. This is important because the women have a shorter urethra. If we analyze this, so the urethra is much shorter. This would be the urethra. And in comparison to the urethra of male patients, the urethra in women is much shorter. Thus, bacteria have less to travel when it comes to the bladder and can easily cause a cystitis. Also, we see that the anus is much closer to the vagina and to the urethra. And in male patients, the anus is not that close to the orifice of the urethra. That is also very important because E. coli is a normal flora in the lower parts of the intestine. So E. coli is normal there, normal flora in these parts of the intestine. But E. coli is not normal in the urinary tract, and our urinary tract is normally sterile. So if the E. coli bacteria manages to change vaginal ecology and colonize the vagina, it will easily cause problems, infections of the urethra, and then even the bladder. So this is a big problem. And also, women, when they enter menopause, they experience vaginal atrophy. And this also causes the change in normal bacterial flora in the vagina. So other bacteria like E. coli can colonize the vagina frequently. So older women have also a higher incidence in urinary tract infection because of this. So the second risk factor in females is also that because of this anatomy, this is also a risk factor in males, but it is affecting females more. So sexual intercourse. So sexual intercourse is making problems because the urethra is shorter. It is communicating with all these other anatomical parts, and it is easier for women thus to develop urinary tract infections. There is also a disease called honeymoon cystitis because of this, because when couples get together on their honeymoon, women after that commonly develop a urinary tract infection because of these, especially because of these anatomical disadvantages, if I can say it like that. The third element is the family history. So it has been proven that in some families where the mother also had frequent urinary tract infections because of some genetical changes, their daughters also have frequent urinary tract infections. And this can be cleared up with simple history taking. These are the factors that are leading to more frequent urinary tract infections in females. And the take-home message is that the female anatomy is a big problem. Because of that, everything is happening more frequently in women. The second group of problems or risk factors that is arising can affect basically anyone. First of all, we need to talk about diabetes. Diabetes, obviously, if it is not treated well, diabetes can raise the blood sugar levels. This will also raise the sugar levels in the urine. And sugar is fuel for bacteria. So the bacteria will then colonize more easily the urinary tract of these patients. Also, diabetes is a complex disease that also can impair the immune system. So it can lower our immune capacity. The second important thing is that diabetes is also damaging our nerve and causing something that is called autonomic autonomic neuropathy. So in this disease, the bladder doesn't function correctly, and the bladder is emptying incompletely. So incomplete bladder, incomplete bladder emptying. And if the bladder enters incompletely, and if we have some urine there, this will be a good place for bacteria to colonize. So stasis, and if we have stasis and obstruction anywhere in our urinary system, that will be something that predisposes this individual for urinary tract infection. Also, obesity. Obesity also lowers our immune response and predisposes us to urinary tract infection. Then an very important risk factor is if there are foreign bodies in our urinary tract. So, for example, stones and catheters. So stones are foreign bodies that form in our urinary tract, and they are good surfaces for bacteria to colonize. Catheters. So there is a disease called catheter urinary tract infection. The catheter is also an inert surface for the bacteria to colonize. And on these surfaces, the bacteria can form something that is called biofilm. And basically, this is a bacterial colonization in which nothing can touch the bacteria. So the only way to treat diseases like this is to remove the catheter or to remove the stones. So the biofilm is a very compact structure that the bacteria make, and it is very hard to eliminate the bacteria in this biofilm. The second possibility are surgeries. So surgery actually damages, we need to do surgery for some kinds of kidney disease, but it can also damage the skin. It can introduce, if it is not done aseptically, it can introduce bacteria, and it can lead, and any kind of surgery can lead to infections. So surgery in the urinary tract can lead to urinary tract infection. So this is basically, these are the main risk factors, and in remembering them, it is easy to understand the pathophysiology. The urinary tract infections are divided on upper, and the upper urinary tract infections are pyelonephritis. So pyelonephritis is an infection in the kidney, and the lower urinary tract infections are basically everything down here. So infections of the bladder are called cystitis, and infections of the urethra, urethritis. Also, urinary tract infections can be complicated and uncomplicated. Complicated infections are happening in, for example, diabetic patients who will get a more severe urinary tract infection and with more resistant pathogens. So patients with comorbidities are getting complicated infections. Patients that are young, healthy patients that have a brief episode of cystitis have so-called acute uncomplicated infections. If we would now analyze briefly the most important elements in the clinical presentation. First of all, we have the term called asymptomatic bacteriuria. So asymptomatic bacteriuria. So asymptomatic bacteriuria basically means a patient has undergone a routine checkup, And we have seen that he has bacteria in the urine. So for example, 10 to the 5th bacteria on the milliliter of urine. But the patient has no symptoms. The patient is not in a risk group. This basically is left untreated, and it is only being checked. So no treatment for this patient. The second group of patients are patients that are developing cystitis or the infection in the bladder, or urethritis, the infection in the urethra. Basically, cystitis will present with a common symptom, and the common symptom is this urea. So this urea is when you have pain when urinating. Also, urinary frequency and urgency. Patient can have also these two symptoms. If the infection is going from the urethra to the bladder, also suprapubic discomfort can be felt. These patients, the take-home message is the patients that have cystitis, these patients have no fever. So they will have no fever in their system. They will not present with fever, and they will have no flank pain. If the patient has flank pain and fever, you need to think about a pyelonephritis. So which is basically an infection in the kidney area or of the kidney. Pyelonephritis, these patients have fevers that are going above 38 degrees Celsius, and they also have flank pain, and they are definitely more complicated and severe than your average cystitis. These patients can also, if the pyelonephritis develops in a risk group, for example, in a diabetic patient. A diabetic patient can develop a special kind of disease that is called emphysematous pyelonephritis. So emphysematous pyelonephritis. In this disease, bacteria that are entering the kidney are forming gas in the kidney and destroying the kidney parenchyma. The only way to treat it is to do a percutaneous drainage of this gas. And even then, it all depends how much of the kidney architecture is left. So the second possibility, the second bad complication is it happens if you have chronic obstruction. So chronic obstruction can lead to a disease called xanthogranulomatous pyelonephritis. Xanthogranulomatous pyelonephritis. So in this disease, the bacteria are actually forming abscesses. So abscesses, big abscesses, are forming in the kidney parenchyma, and this can be so severe that it damages the kidney so severe that the kidney needs to be removed surgically. So a nephrectomy needs to be done because of these intraparenchymal abscesses. And if you don't do that, the patient will definitely die of sepsis, because the infection will not stop at the kidney. If the patient is in a high risk group, the infection continues into the blood and causes sepsis, so urosepsis. And this is now a very severe complication. So basically, these uncomplicated infections that are cystitis, urethritis, and cystitis infections they can be treated only on the patient history. So if you see that the patient has dysuria, urinary frequency, but no fever, and probably it is a young woman that already had one at some other time, you can treat it based on the patient history. But if you see that the patient has fever, flank pain, you should do a thorough physical exam and analyze if this patient actually needs more diagnostic, and if it is a complicated, if it turns out to be a complicated urinary tract infection, you will need to do a urinalysis, you will need to do a urine culture, an antibiogram, and see what pathogens are on what antibiotics sensitive to give to this patient immediately, probably intravenously. And some of these special kinds of complications need to be treated in special ways. So this is for the first part. Thank you.